Good morning, delegates and faculty members. Thank you for joining Shield Connect. And today we are back with the series, a virtual learning series 3 on preeclampsia, sponsored by the Society for Maternal Fetal Medicine India. So let me introduce our MOC for today's session, Dr. Anu Joseph. Ma'am is consultant and medical director at Trinity Healthcare Clinic in Electronic City. Along with that, ma'am is also consultant in Kaveri Hospital and then visiting consultant in Aspire Fertility Center, Motherhood Hospital, and Narayana Multi-Speciality Hospital. Area of interest is first trimester aneuploidy screening and prevention in high-risk pregnancy. Ma'am has also received a award and recognition for EC member SMFM and event coordinator of our VLS PE 2022-23. So, ma'am, I hand over the session to you and please take over. Thank you.
Thank you, Nishant. First of all, welcome to one and all for today's series on virtual learning series on preeclampsia. This is our third session in the same topic, preeclampsia. Today we will be dealing more management of preeclampsia, hypertension in general and preeclampsia in specific. It is my proud privilege to introduce all our presenters and delegates for today. Dr. Prakash Mehta sir needs no further introduction to most of you. He is our guiding light and he is the president of the Society of Maternal Fetal Medicine, India. Sir at present works as the head of department and the chief of division of maternal fetal medicine in Bhagwan Mahavir Jain Hospital, Bangalore. Sir is also the co-chair for the PENAI program and the organizing president for the upcoming ICEP World Congress 2023. Sir is an expert in high-risk pregnancy and has been awarded various awards as the best teacher and also has been awarded the Lifetime Achievement Award from the BSOG in 2021. Welcome to you, sir. I would like to call upon Dr. Sarosh Rana. Madam is our chief of maternal fetal medicine and professor of obstetrics and gynecology in the University of Chicago. Madam is very much interested in research on preeclampsia, and she holds an important post in the ISHIP, which is International Society of Hypertension in Pregnancy. Welcome to you, ma'am. Ma'am has not joined in as of now, if I'm not wrong, but she would be joining us soon. I would like to invite upon Dr. Revati. Dr. Revati is our Secretary of Maternal Fetal Medicine India. She is also the co-chair for Preeclampsia Education of the Nation and organizing secretary for the ISHIP World Congress 2023, which will be held in Bangalore. Dr. Revati's interest has been always in particular with hypertensive disorders and in utero-fetal programming, and she can go on and on about the topic, which has been very close to her heart from the time I know her. She's very much interested in her research and has been awarded UA Foxy Award multiple times and has been awarded the Certificate of Excellence for Research and Young Scientists at the Second Academic Brand Awards. Welcome to Dr. Revati too. Going ahead with today's panelist, Dr. Virendra Kumar. Sir is somebody whom I have known from my PG days. 3 years of wisdom, which was always held in Bellary, in WIMS Bellary as a part of PG training program. Wonderfully organized, a wonderful organizer, and above that, a wonderful teacher. The way he speaks about any topic, and in particular preeclampsia, has been something of great interest as a student in me, and then meeting him virtually after so many years has been a blessing. Sir is a present president of Bellary OG Society, and he's worked as secretary of Bellary Obstetrics Society, IMA Bellary, and he has been the chief coordinator for the Wisdom PGCME. He has been the organizing secretary secretary for the 30th State Kasoga Conference, and he has been the trainer for hypertension in pregnancy in certified courses. Sir has published various papers and contributed to various chapters in various textbooks. Welcome to you, sir. It has been a proud privilege for me to be welcoming you and not the other way around. I don't know if you remember me.
Yeah. Thank you, Anu Joseph. And incidentally, Anu Joseph won the best prize in our wisdom. So she had the talent in the PG days itself.
Thank you so much, sir, for remembering. It's a proud privilege. Next, I would like to welcome Dr. Kasturi Donimath. Madam is the present president of Kasoga 2022-23. Madam is also the professor and HOD of KIMS Hubli, ex-secretary general of Kasoga and ex-treasurer of Kasoga. Madam has been working with the Hubli Dharwad OBG Society and remained the ex-president and the ex-secretary of the same. Madam is into research in various fields in OBG and has been the co-investigator for international research projects. She's also the MCI inspector and has been the examiner for various UG and PG examinations in various universities. Welcome to you, madam. Hope you have a great day participating with us in our conference today, and also welcome to you as our new family member to the SFMI group.
Thank you.
Next, I would like to introduce our own Dr. Shruti K. Prasad. Dr. Shruti is a fellow in fetal medicine and practices fetal medicine. She is currently working with Cloud9 Hospitals and her own Novita Fetal and Women Clinic. Her interest has been almost always with the fetal interventions, fetal cardiology, and ultrasound in obstetrics. She has been the executive committee members with us in SFMI. Also is a member of Indian Academy of Medical Genetics. Welcome, Dr. Shruti.
Hi.
It is my privilege to welcome Dr. Mohammed Azam, not specifically from the OBG community, but from a department which is very, very close to our heart, anesthesia. And sir is specifically interested in obstetric anesthesia, regional anesthesia, and critical care. And like any other time in obstetrics practice, it is a privilege to have an anesthetist with us whom we can rely on. Thank you, sir, for being here.
Thank you, ma'am.
And welcome.
Thank you so much.
Dr. Srimati, madam, is consultant at Rangudare Medical Memorial Hospital, Bangalore. The way madam talks about things in high-risk pregnancy makes us realize how much she cares about obstetrics and high-risk pregnancy. I have listened to her multiple number of times, and it has been always an awe with which I have listened to her. She makes even very, very difficult and probably a little too complicated things very simple to understand. And it's been always great to have listened to her teaching us regarding whether it be anemia, preeclampsia, or any other topics in OBG. Welcome to you, ma'am. And madam specifically is RCOG certified person as well as an MRCOG examiner. She's a reviewer for the Green Journal and also a DNB trainer and trainer for the RGHS fellowship programs. Welcome to you, ma'am.
Thank you. Thank you, Dr. Anu, for your kind words.
Next, I would like to call upon our own Dr. Sunita. Madam has been our teacher, my teacher specifically, colleague, and also a great friend, a person whom we can always rely upon when in need. Presently, madam is a medical director and senior consultant, maternal fetal medicine at MIL in Bangalore. Madam's areas of interest is high-risk ART pregnancies and management of recurrent pregnancy losses. She has been the executive committee member for BSOG as well as SFMI. And at present, madam is also the chapter formulation coordinator for SFMI. Welcome to you, ma'am.
Thank you, Doctor.
With that a short introduction to all our participants for today, the panelists for today. I would now like to call upon Sir Prakash Mehta, sir, for your presidential address and inviting all the delegates and to the program.
Good morning, everybody, and it's nice to have you all on this program. This is the third in the series of pre-eclampsia education program that we are doing with the support of Shield Pharma. Today is one of the excellent days for us because we are welcoming a new baby into our fold. The chapter of SMFMI Hubli Dharwad is going to start being inaugurated today. We are a small society of very closely knit people interested in high-risk pregnancy. We are hardly about 3 years old, and we started with a program called the Preeclampsia Education Nation of India program, which of course we'll be talking a little bit, Dr. Revti will be talking a little bit later. And we have Dr. Sarosh Rana as one of our mentors for this program. Through the International Society for Study of Hypertension. And I'm also glad to announce that the iShip 2023 is coming to India for the first time. Rather to the Asia for the first time, except maybe Japan a few years back. No other country in Asia has ever held the iShip conference, and we are holding it in Bangalore for the first time in September 2023. I would request all of you to not just join the conference, but to ensure that you present some kind of a research paper, because presenting a paper in the iShip International Conference is very prestigious. So please encourage all your juniors to use this opportunity to present papers in this conference. I would now request Dr. Sarosh Rana to say a few words. Dr. Sarosh, please.
So, ma'am.
Hi, everyone. Sorry.
Before Dr. Sarosh proceeds further, I must tell you she has joined us at midnight. She's in Chicago and it's almost midnight. So that goes to show interest in teaching of preeclampsia.
Thanks, Dr. Mehta. Thank you, everyone. I was like literally sleeping. My alarm went off. But anyway, congratulations, everyone. And thank you and welcome for joining us. And I think I'm going to check out, but you guys carry on. So really, I agree. It's really amazing that so many people are here. And and the iShip 2023 is in Bangalore next year. So I really am looking forward to see everybody in person. So again, welcome everyone. How many delegates do we have in SMFI right now?
Right now, this is the third chapter we are inaugurating. We have Mysore, we have Salem, now we are Hubli Dharwad. Okay. Next on the list is, I think, Aligarh, Lucknow. And then we are moving.
I hope it's Aligarh because I know
every program one chapter. That's how we are planned out.
Okay, great. So Bangalore was the first chapter then?
Yeah, Bangalore, we are 2.5 years old.
Okay, good. Yeah, very nice. Yeah, and hopefully you guys will learn about about the Penai project too. I know Revati is going to talk about that. So welcome everybody.
Now, before Dr. Sarosh Rana, you leave us, I must tell you that for the Penai program, Bangladesh and Nepal people have started registering now.
Oh, that's amazing.
So, yeah, we are spreading our wings across all the rest of the Asia.
You know, one thing I was thinking that perhaps we may need to update some of the lectures in there. I don't know. Revati, you probably need to look at them all. Some of them are a couple of years old, right? 2 years. How long Penai has been going on?
Penai is now 7 months, Revati.
Oh, okay, 7 months. We should annually review like all the lectures in there and make sure they're still up-to-date information.
Yes, I think we should do that. Yeah. Whatever changes are coming.
Whatever changes are happening, yes. And based on feedback from people, maybe we should like review everything every year. But yeah, that's amazing that they're registering from Nepal and Bangladesh. That's fantastic. And you know, one of the things I was saying is that hopefully, let's see if I get into the leadership with iShip, because that would be one of our things to do. Would be one of my goals would be eventually to like put Penai in every country. I'm not even kidding.
So thank you very much for being with us. Have a great, I should say, have a good sleep.
I'm gonna sleep off, but I'll try to listen in as much as I can.
Thank you.
It's so nice to see everyone.
Yes, Anna.
Thank you so much, ma'am. Thank you, sir. So with the welcome address and the presidential address done, we will go now into listening in short about antihypertensives and their role in management of hypertension, in particular preeclampsia. For this, I would like to welcome Dr. Srimati. Madam, please, you can start with your presentation.
Thank you, Dr. Anu. Just going to share my screen. I hope my screen is visible and I'm audible.
Yes, ma'am.
Yes, ma'am.
Thank you. So good morning, everyone. I welcome you all to this learning series. And before I start, I should give my hearty thanks to Prakash Mehta sir, without whom I wouldn't be here. And of course, Dr. Revati and SMFMI for having given me this opportunity. So what I'm going to be speaking is give a bird's eye view of antihypertensives, when, what, and how. I know it's a big topic, and in 10 minutes, it's going to be a bit difficult to cover most of it. But what I'm going to give is a sort of a bird's eye view. So the question is, when should we be starting? So what threshold are we looking at? Is it going to be different in pregnancy? Should it be different in pregnancy? So that's going to be the first one. So if you just briefly look at a non-pregnant adult, we diagnose stage 2 hypertension when the systolic blood pressure is more than 140 and the diastolic blood pressure is more than 90. And what is the recommendation? If the blood pressure is stage 2, even if they do not have any, sort of pre-existing comorbidities, it is recommended that they are being started on antihypertensives in order to decrease the cardiovascular events. So what is happening in pregnancy? Universally, all guidelines recommend that severe hypertension, which is systolic of more than 160 and diastolic of more than 110, should be treated because we are worried about complications. But if you look at non-severe hypertension, there has been lots of controversy and varying recommendations by the various guidelines. So why is this disparity? First, let's just take a minute to think about it. Probably because we are still debating on the etiology. We also are worried that, lowering blood pressure may affect the baby. And of course, it may not have any effect on the pathogenetic process. And also, we are worried about the safety of the drugs for the fetus. But is it actually true? So if you look at the NEJM trial in 2015, the CHIPS trial, which was published, they looked at, giving treatment to women with diastolic blood pressure of 90 to 105, treating them to a tight control of less than 85 or a normal control of 100. And what they found was there was no major difference in the primary or in the secondary outcomes, but definitely severe hypertension was less common in the women who had the tight control group. So this was statistically significant. So they concluded that antihypertensive treatment definitely decreases the risk of having severe hypertension without having any major perinatal risk. So Cochrane in 2018 came to a very similar conclusion and said that antihypertensive therapy for mild to moderate hypertension definitely reduces the incidence of severe hypertension. So now moving forward, we have the CHAP trial, which was published in May 2022 and again in NEJM. This looked at active treatment of women who had non-severe hypertension, and they found that the incidence of a primary outcome was definitely statistically significantly lesser in the active treatment group compared to the control group. And what are we worried about? We are worried about SGA babies, and this was no different. And so they found that, the preeclampsia and its complications and prematurity was definitely reduced. If you're going to treat non-severe hypertension, 14 to 15 patients would need to be treated to prevent one primary outcome. But mind you, one point which we would need to remember is both the CHIPS and the CHAP were based upon chronic hypertension, but we expect the results are not going to be marginally, we're not going to be substantially different, even if it's going to be gestational hypertension. So where do the recommendations currently stand? WHO in 2020 does recommend that women with non-severe hypertension should be treated. NICE also has a similar recommendation, and ISHIP 2022, that is the latest guideline which has been published. They have also been very clear. You start the antihypertensive treatment even for non-severe hypertension. There is no doubt about severe hypertension. So the reason I've been speaking about all these is because we should also treat non-severe hypertension. And irrespective of the etiology, whether it is gestational hypertension, preeclampsia, or whether it is chronic hypertension, irrespective of the etiology, we are going to be treating them with antihypertensives. So the take home is we would be starting for even non-severe hypertension, regardless of the etiology. So the next question is, what medications am I going to use? Is it going to be safe for the pregnant women? Is it going to be safe in breastfeeding? Is it contraindicated? So to answer this, I will look at a few trials. This was a meta-analysis which was published in 2020. They looked at nifedipine, methyl-dopa, and beta blockers, and they found that nifedipine and methyl-dopa was effective in decreasing severe hypertension as well as decreasing abruption rates. Atenolol and to a certain extent labetalol were actually associated with SGA infants. This was followed on by another meta-analysis published in 2022. Here again, what they found was there was a slight increased risk of SGA infants with labetalol and beta blockers, but preterm birth was definitely reduced with labetalol, as well as labetalol was a only antihypertensive agent which could decrease proteinuria and perinatal death. So again, these two meta-analyses were mainly based upon women with chronic hypertension. So what is the antihypertensive which we would want to start? So we are very happy with methyl-dopa, labetalol, and of course calcium channel blockers, beta blockers, and diuretics. We would want to use it provided the other antihypertensives are not suitable or are not working. So which one would you want to choose in this? So there is no specific recommendation. ISHIP says we can treat with any of these first-line agents. NICE though gives a specific recommendation saying consider labetalol, especially if it's a chronic hypertension. But of course, if it is not suitable to use labetalol, you could use the other first-line agents. So then how do we choose? So based upon the drug availability, because at few places we do not have methyl-dopa, freely available. So based upon the availability of the drug, look at what is the cost. Look at the particular patient characteristic. Maybe she has a baseline bradycardia. Maybe she has got a baseline tachycardia. So look at the patient characteristics. Look at what treatment has worked for her previously. Of course, the preference of the physician and the patient comes into play. And also particular contraindications, because if they are a poorly controlled asthmatic, we may not be able to give them labetalol. So remember all of these things when we are starting antihypertensives. And of course, remember the side effects so that we can monitor the mother as well as the baby. So now the critical question. So now we have decided when to start and what antihypertensive to start. How are we then going to treat it? So first, let's take severe hypertension. So this was again a meta-analysis, and they looked at 3,200 women. And they found that parenteral labetalol was very similar to parenteral hydralazine or oral nifedipine. In fact, nifedipine seemed to require fewer doses than hydralazine. We also had another meta-analysis in 2019, which again showed oral nifedipine was very successful in treating severe hypertension with lesser side effects, and it was the lowest incidence of hypertensive episodes compared to hydralazine. And there was not a major difference between labetalol and hydralazine. And this was a very interesting trial, which is probably applicable to a majority of the low middle income countries. This was done from India, and they looked at 894 women with severe hypertension, and they gave them only oral antihypertensives. In fact, they gave them only nifedipine retard. So they gave them 10 milligram every hour to a maximum of 30 milligram, labetalol 200 milligram to a maximum of 600 milligram, and methyl-dopa 1 gram, 1 dose. And they looked at the antihypertensives and their effect on blood pressure control within the first 6 hours, and they found that all of them reduced the blood pressure to the reference range, and nifedipine retard was the best, and less than 1% of the women required antihypertensive intravenous medication. So this goes to show that we don't have to be, sort of thinking only about an intravenous medication for reducing severe hypertension. Oral antihypertensives also work. So if we do not have access in our primary centers, we could definitely think about giving any of these oral antihypertensives. It is definitely going to at least reduce the incidence of complications in the mother and of course on the fetus. So what is the take home for severe hypertension? You can give either oral nifedipine, oral labetalol, or IV labetalol, or IV hydralazine. You would definitely want to avoid sublingual nifedipine because it can suddenly reduce the blood pressure, because of which you can have cardiovascular problems. So this is the ISHIP guideline, which gives us clear guidance about how we are going to use oral or IV labetalol and of course nifedipine. So I think this is sort of a ready reckoner for us to go back to so that we can manage severe hypertension. But once we have given them IV or oral antihypertensives to bring down the severe hypertension, we would need to maintain them with oral antihypertensives. And of course, if there are non-severe hypertension to begin with, we would want to give them maintenance oral antihypertensives. So as I was discussing before, you choose the medication based upon the particular patient characteristic, either labetalol, nifedipine, or methyl-dopa. And here again, this ISHIP guideline gives us very clear guidance about how we are going to escalate it. So we have low, medium, and high. So we would want to stick to medium dose whenever it's possible to achieve the target blood pressure range. If, of course, the target blood pressure is not reached, then we might have to escalate to high dose or add another antihypertensive from a different class. Amlodipine is being widely used but there are very little data of its use in pregnancy. This is something which you would need to keep in mind. So the data is mainly for labetalol, nifedipine, and methyl-dopa. And this is the recommendation for how we are going to use non-severe hypertension. So then what are we looking at the target? Because I said if the target is not achieved, you would have to go higher, escalate it. So what is the target we are looking at? So diastolic blood pressure between 81 to 85 millimeters of mercury is a target. So if you are able to consistently achieve this target, we are not going to change it. Whereas if the diastolic blood pressure consistently becomes less than 80, we might have to decrease the antihypertensives or maybe even consider stopping. Of course, if the diastolic blood pressure is consistently above 85, we would definitely want to hike up the medications, or if they are not on medications, start them on medications. Here again, we would need to pay attention to the systolic blood pressure as well. If the systolic blood pressure is consistently above 160, even if the diastolic blood pressure is in range, consider hiking up the antibiotics. So what is the target then we are looking at? This has been inconsistently defined in earlier guidelines, but we have strong evidence from the CHIPS trial. So the recommendation now is maintaining a systolic between 110 to 140 and 80 to 85 millimeters of mercury. Now, moving on, are we going to look at a different management in the postpartum period? Definitely not. So treatment of severe hypertension, target blood pressures, all of them are going to be very similar as in the antenatal period. And it is very important that we continue the antihypertensives in the postpartum period, because preeclampsia, as we all know, may worsen or just appear de novo in the postpartum period. So this is very important for us to remember. Slight tweaking of the medications might be needed. If they are on methyl-dopa, we would want to consider them to a different antihypertensive because we are worried about postpartum depression. A few other antihypertensives have been added on. We would be able to give them ACE inhibitors like enalapril and captopril because they are considered safe in breastfeeding, and of course metoprolol. But otherwise, the management is very similar to the management in the antenatal period. So this is something which we would need to remember. Let us not be very, sort of reduce our threshold for treating. As per ISHIP latest guideline, we would want to treat them like in the antenatal period. Of course, we need long-term data about the effect of these antihypertensives on the mother and the offspring. We do not have enough long-term data, but this is some research data which we probably are going to look forward in future, which will give us more information about how they affect the mother and the baby in the long term. This is an interesting concept, personalized care based upon their demographics, based upon their ethnic origin, based upon their heart rate and stroke volume. I mean, this is being used to a greater extent in the West. People who are of Black race, they seem to respond more to nifedipine compared to labetalol, but the data is very, very limited. So here again, this is an exciting field of research, and hopefully we will get more data in the future. So with this, I would conclude by saying that antihypertensive thresholds would be both non-severe as well as severe hypertension. So when the blood pressure is more than 140/90, please consider starting antihypertensives. Choose the medication based upon the individual circumstances. You would be fine choosing any of the first-line antihypertensives. Aim for a target diastolic of 85, but also remember the systolic should be at 110 to 140 and definitely not near 160. Remember counseling these women, and of course, long-term follow-up of the women as well as the child, because they are at risk of, the in utero programming, as was discussed by Dr. Anu earlier on, because this is going to have a long-term impact on the offsprings in future as well. For this, I would like to conclude. Thank you very much for the opportunity.
Thank you so much, ma'am. Thank you for that very lucid and very to the point presentation. I hope everybody would have understood about what to use, when to use, how to use, and the importance of actually using medications to control and manage preeclampsia and other hypertensive diseases of pregnancy. Next on call, I would like to invite, thank you. I would like to invite Prakash Mehta sir for starting with a panel on management of preeclampsia. Along with sir, I would like to invite our other esteemed panelists, Dr. Virendra Kumar, Dr. Kasturi Donimath, Dr. Shruti Prasad, and Dr. Muhammad Asam.
Good morning, everybody, once again. Just to reiterate, the International Society for Hypertension for Study in Pregnancy, the ISSHP guidelines will be discussed in detail in our September 2023 conference, and all the changes that are coming in 21 and 22 will also be presented at that time. So to know these latest guidelines, please don't miss that conference. Okay, with this we go over to the management of preeclampsia, and to discuss this management, I have with me
Alert from
as
reminders.
panelists.
Added.
Sorry. Okay. To discuss this management, I have fantastic people with me. These are the people who are not just managing preeclampsia day in and day out, but these are the people who are doing a lot of research and a lot of study about preeclampsia. So hearing from them would be an excellent opportunity for everyone to learn. As already announced, I have Dr. Kasturi Donimat, I have Dr. Virendra Kumar, I have Dr. Azam, and I have Dr. Shruti Prasad as panelists.
So can you please make it in full screen?
Sometimes in life, everything goes smoothly.
Prakash Mehta,
And
sir.
sometimes unexpected happens.
Prakash Mehta, sir. Sorry.
Yes.
Can you make it a full screen, Prakash Mehta, sir?
I thought it was full screen. Okay.
Yes. Sorry, sir.
Is it full?
Not it, sir.
It's showing me full here.
Onto the PowerPoint mode and change the display, sir.
Okay, but it seemed well, no? We go
Yes,
ahead. No problem. So, but sometimes unexpected happens in life, and preeclampsia is a condition where most of the time unexpected things happen. Now, before we go further, I have a very few simple questions for all our delegates. Please answer it to yourself, and at the end of the session, see if you're going to change your protocol or not. The first question is, you order platelet count for whom? All pregnant patients? Generally, I don't order platelet count. All hypertensive pregnancies, or only in patients with severe hypertension? The second question, do you order LDH estimation on hypertensive patients? No. Yes on all patients. Occasionally. It's not a part of liver function test in my lab. Most of your laboratories, if you ask for an LFT, do not give you LDH values. And what do you do when a patient telephones you with a complaint of epigastric pain at 26 weeks gestation? Prescribe antacids on an outpatient basis, refer to gastro department or to your internist, ask her to come in for admission, or ask her to come to the office next day for a detailed examination and investigations. So I hope you answer all these questions to yourself, see what our panelists have got to say, and then see whether you need to change your protocols or not. Now we know that preeclampsia is a multi-system progressive disorder. Many maternal and fetal deaths or near misses are associated with substandard care. That is why we came up with the Preeclampsia Education of the Nation India program, because substandard care is the biggest killer of women with preeclampsia. And remember, the progress is not always a sequence. I mean, when the time that we were undergraduate, it was always told that you have a mild preeclampsia, which becomes a severe preeclampsia, and then the patient throws a convulsion. Now we know that that is no longer true. The patient can jump from mild eclampsia to eclampsia straight away. I'm sure anybody who has been managing eclampsia patients will vouch for this statement. And also remember that in the health syndrome, 15% of the patient will have no proteinuria, no hypertension. So, you know, our definitions are kind of changing a little bit here and there. And 30% of eclampsias will have only mild hypertension and no proteinuria. So with this, I go to the first question, goes to Dr. Virendra Kumar. How do you classify hypertensive disease in pregnancy?
Sir, hypertensive, can you hear me?
Yes, please, sure.
Hypertensive disorders in pregnancy basically are classified as gestation hypertension, chronic hypertension, preeclampsia, and hypertension superimposed on preeclampsia. So this is the easy way to remember the classification.
Absolutely. So the ISHIP 2018 says exactly whatever Dr. Virendra Kumar has said. And we should never forget the category of preeclampsia superimposed on chronic hypertension, because unless you are handling these cases now and then, you are likely to miss. You may just feel that the chronic hypertension is increasing because let's say you have a patient with nephrotic syndrome albuminuria is already there, and you are quite likely to miss such cases. Okay, so we now classify preeclampsia as with severe features or without severe features. Now, with this, I'll just quickly take you through one case. She's a 32-year-old primary gravida, IVF conception well booked, presented with a BP of 140/90 at 36 weeks of gestation. Her 12-week scan was absolutely normal. The uterine artery Doppler was screen positive for preeclampsia, negative for aneuploidy. The present investigations are all within normal limits at 36 weeks. With this, the question goes to Dr. Kasturi Donimat. What is your diagnosis and why? A 36-weeker IVF pregnancy with a BP of 140/90, all the blood tests are normal. Dr. Kasturi? I think there is some signal problem there. Dr. Virendra Kumar, can I ask you to take the question?
Yes, sir. Yes, sir. Sir, this is a case of gestational
So I'm audible?
Yeah.
Oh, yes, Dr. Kasturi, you're audible. Sorry.
Okay, sir. Something went wrong with the connection in between.
I know.
Okay. Yeah. So she'll be primary with mild preeclampsia. I think urine albumin was positive, no, sir? In between, I lost.
Everything, all tests normal.
Yes, sir. I lost connection, so I didn't see the previous slide.
Oh, okay. I'll tell you the case again. It will be good for our delegates also to hear. This is a 36-weeker IVF pregnancy, came in with a BP of 140/90.
Okay, sir.
Her first trimester scan was screen positive for preeclampsia. Now she's 36 weeks, BP 140/90. All blood tests, urine tests, everything is normal. So now what is your diagnosis?
So she'll be primary with 36 weeks with gestational hypertension, sir, because urine albumin is negative. With IVF, with precious pregnancy, because she's IVF conceived.
Absolutely.
She needs to be reassessed, sir. She needs to be reassessed. Her proteinuria has to be assessed every day and see whether she ends up in preeclampsia from gestational hypertension.
So absolutely, any hypertension de novo arising after 20 weeks, in the absence of proteinuria, without biochemical or hematological abnormalities, needs to be confirmed by repeat reading, and most of the time it's going to be a gestational hypertension. Next question again to you, Dr.
Can I make a comment, sir?
Yeah, please.
Yeah. Sir, we should remember that anybody who has undergone frozen embryo transfer, according to the recent study, they are at higher risk of developing hypertension, number one. And as per the double marker test and the 12 weeks, the Papa levels are less than 10th percentile because they are only 0.5 multiples of median. So again, that also gives a clue regarding counseling the patient for the possibility of development of hypertension. So these two things needs to be kept in mind.
Absolutely, and like Madam said, we have to follow up. It's just not giving up. Okay, you're just simple gestational hypertension.
Yes.
We forget about you. No, that cannot be done. Next question again to Dr. Kasturi. What is white coat hypertension, and are there any implications of that white coat hypertension? I think we have lost Dr. Kasturi again. Right, Dr. Virendra Kumar, we come back to you.
Yes, sir. White coat hypertension is not to be neglected actually. Patient says that whenever she comes to the office settings, her blood pressure are high. When you check her blood pressure in the ambulatory settings or at home, it is absolutely normal. But all said and done, these are the patients who are likely to develop complications little later in pregnancy, or they are the candidates for developing essential hypertension at their later part of their life. So white coat hypertension, even though it looks normal at home and is always elevated at the office setting, there needs to be have higher surveillance for the development of complications.
Absolutely. So we should never forget that it is not a completely benign disorder. It can be a potential pre-runner for preeclampsia, and these patients again have to be followed up. Just don't say, lady, you're nervous. You come into the hospital, your BP is normal, you go home, your BP is abnormal, and you go home and your BP is normal. So don't treat the patient that way, follow her. Okay, Dr. Shruti, this question to you. What are the screening tests available for preeclampsia, and are there any new tests?
Yes, sir. So screening test, as by the name itself, screening means before the disease process sets in, we're going to screen that patient, treat her so that we are going to modify her background risk. So first trimester screening includes ultrasound and also biomarkers. So ultrasound, we do the uterine artery Dopplers. And if it is screen positive, just we don't start on ecosprin by just looking at the uterine Dopplers, but also modify the risk factors based on her parity, like the history, and then previous history of preeclampsia, previous history of small baby, family history, teenage pregnancy, the risk factors, and also then add the uterine artery PI, take the mean arterial pressure, that is in the OPD itself, measure both the blood pressure in both the arms and take the average of it. That can also be included in risk screening. And also we are going to add the markers. Most importantly is a PAPA. Along with that, the newer, we have the PLGF and the SFLT. So combining all these parameters, both ultrasound features, history, and the biomarkers, to most extent, we can screen who are positive and start them early risk modification from the first trimester itself.
Yeah, sure. So these are very important, and we know that Laura Maggie has been associated with a lot of screening and preventive strategies. Of course, she will be in Bangalore in iShip 2023. And I think since I'm definitely going to request her to speak on the preventive aspect of preeclampsia so that we hear directly from her as to how we go about doing prevention. Okay, she went through the screening test, Dr. Shruti. She was screened positive.
Yes, sir.
Now she developed hypertension, but not preeclampsia, at least not now, preeclampsia. What does that mean? What does screen positive indicate?
Screen positive indicates that she is likely to develop preeclampsia, and it's not that all cases of who are screen positive will develop preeclampsia. So some cases may not develop. Suppose the patient comes and the uterine artery is positive in the first trimester, and we start them on ecosprin and we see again in the second trimester, we should not stop the ecosprin. That's a common mistake which is commonly done. Starting ecosprin will modify her risk for developing early onset complications. We cannot, and the severity of the complications. And we can postpone the complications to a later date of the end of pregnancy where things are still manageable. So that is the meaning of screen positive, but developing hypertension. The severity of the symptoms and the severity of the disease gets modified by this screening and treating risk modification.
Absolutely, but there are two other important points. One thing is that we call it a screen positive for preeclampsia, but she may not develop preeclampsia, but develop fetal growth restriction. That's
yes,
one point.
Yes, that is also indirect.
The screening tests are mainly meant for early onset preeclampsia rather than late onset. Okay, we heard a lecture from Dr. Srimati, a wonderful lecture on antihypertensives, but we all know that how much ever we hear, we are always confused. So to clear this confusion, Dr. Virendra Kumar, now this patient we have so far diagnosed as gestational hypertension. So antihypertensives for gestational hypertension. When to start, when to step up?
Sir, a few years back, many of the societies had different guidelines for starting antihypertensive therapy. Because one school of thought is that if you start antihypertensive therapy at 140/90, many argued that it would result in low birth weight and the low birth weight of babies. So they would recommend starting antihypertensive at 150 or more than 100. But this idea is again questioned by many because in India, as you know, compliance among the patients is very poor. What is mild can suddenly become severe, as you told in the beginning of our lecture. So I would start, or even the recent guidelines would suggest, start antihypertensive therapy the moment you diagnose hypertension at 140/90. So this is, we have to remember, 140/90 or any severe hypertension, even though the diastolic blood pressure is 80 or 70, Even if you have isolated systolic hypertension, then also we need to start. And we should remember that systolic hypertension predicts the maternal complications, and diastolic blood pressure is more for fetal complications. So by starting antihypertensive therapy at 140 by 90 or more than that, we will be achieving the safety of both mother and baby.
Absolutely, but I'm very sure, Dr. Virendra Kumar, both you and me were using antihypertensives at 140 by 90, even 10 years back and even 20 years back.
Yes, 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 sir.
We never bothered with what they said. We said 140, 90, they're going to treat. And ultimately now the guidelines have swung back to 149.
Yeah. Even 10 years back, we used to argue that we should start at 140 by 90 when the evidence-based medicine people used to criticize us for starting antihypertensive at 140 by 90. But now again, it's come back to the same position.
Okay. Dr. Kasturi, are you? Yeah. Yeah, Dr. Kasturi, the next question for you. What investigation will you order in this patient? Now we said gestational hypertension. What investigations will you order for detection of complications?
So yes, we do detailed investigations like CBC to identify any thrombocytopenia and hemoconcentration. Then everything: urine protein creatinine ratio, LDH, liver function test. We are doing a whole investigation, sir. Renal function, liver function, and peripheral smear for evidence of hemolysis, and to identify any problem in other organs like fundoscopy, any retinal changes, and all these routine investigation we are doing, and ultrasound, detailed ultrasound to see the fetal status, fetal Doppler, growth, to detect IGR.
Absolutely, but one question I would like all my panelists to answer. Will you order 2D echo on these patients? She's gestational hypertension, mind you, she's not yet preeclampsia, she's gestational hypertension. Will you order a 2D echo?
So this thing is, pre-COVID, we were not doing so much, but post-COVID, we have started doing more of echoes because we are seeing lot of peripartum cardiomyopathy cases, even in mild preeclampsia cases.
Sir, can I add, sir? Hello?
Yes, Dr. Virendra Kumar.
Sir, actually, Canadian school of thought, they say that actually preeclampsia or just whatever you call HDP or gestational hypertension is essentially cardiac disorder. And because we have seen many patients mild preeclampsia or mild gestational hypertension going for cardiomyopathy later, some of the patients. So it is a wise decision to order 2D echo for all hypertensive patients.
Absolutely agree, because I'm sure again this will be discussing in ISHIP 2023.
Yes.
Now there are a school of thought which says it is the cardiac problem that is causing preeclampsia. The placenta is incidental.
Yes.
Placenta is a victim, not the cause for the disease. So a lot of research work is going on. By 2023, we'll definitely have some answer. Next question.
But it's definitely indicated for severe preeclampsia patients. Sir.
Absolutely.
Yes.
So one lesson, one carry home message definitely our families are giving is that if you have a patient with hypertension, please do a 2D echo on that patient. It will be worthwhile.
Yes.
Now this patient with gestational hypertension, how will you monitor her further? Dr. Virendra Kumar.
Yeah. So any patient who presents with hypertension should not be neglected, whether just because she has gestational hypertension without proteinuria. So we need to monitor her for development of complications. Since luckily this patient has developed hypertension beyond 36 weeks, the fetal salvageability is excellent in this case. And patient should be monitored for development of symptoms and complications clinically. And laboratory wise, we have to weekly twice we have to get liver function test and serum creatinine and urine albumin. So by this we are knowing whether the disease is progressing or not. And of course, fetal surveillance is also required in terms of NST and fetal Doppler and amniotic fluid index.
No, I'm sure all of us would have come across patients where the neighboring auntie would have told, "Oh, BP 140/90, don't worry, nothing is going to happen. Don't even go to doctor. If you go to doctor, they'll do cesarean section." And then the patient comes to you either with HELLP syndrome or eclampsia. So please remember that gestational hypertension is not benign. You don't have to take an urgent management decision, but you need to definitely follow up and not miss it. And of course, now in the era of biomarkers, we can either do a split PLGF ratio or a point of care glycosylated fibronectin, and we can definitely prognosticate them into those who are going to worsen and those who are not going to worsen. So that kind of a help has now come in with the use of biomarkers.
So not only that, and because already she has developed hypertension, and I would like to terminate the pregnancy the moment she reaches more than 37 weeks.
Even in gestational hypertension?
Yes, sir. Because in this case scenario, it is a high risk pregnancy, so we don't want to take any chance in such patients. It all depends on, we have to individualize the treatment, of course.
But if I tell you it's a primary gravida, married for 1 year or 2 years and has a BP of 140/90,
yeah,
all biochemistry normal, she's an educated girl coming to you for follow-up.
Yes, those patients can be definitely be allowed for another 1 to 2 weeks.
Absolutely. The next question comes to you, Dr. Kasturi. When and how will you deliver them?
Yeah, this is a very. Hello.
Yes, please.
1 minute.
Hello?
This very important. This is a day-to-day dilemma. This is a day-to-day dilemma. 1 second, because there is 1 second. I'll log in from 2. I'll log in from 2. Okay, I think I'm audible now. Okay.
Yeah, now you're audible.
Yes. So this is very, very important. This thing, greatest dilemma in our day-to-day practice. When to deliver, because I know up to we want to continue all the pregnancy at least minimum up to 34 weeks. So mild everything we are continuing up to 34. At 37, it is very clear we have to deliver. But our biggest question is between if this patient presents with 34 to 37 weeks, what to do? Whether should we deliver or should we intervene immediately? So what practically we are doing is gestational hypertension. Of course, we are with serial investigation, serial monitoring. We are continuing them with up to 37 weeks. But when they end up in preeclampsia, I think it's lots of dilemma. We are doing it case to case basis when to deliver and when to, because there is no clear cut guidelines. Up to 34, I know there is a clear cut guidelines. Some who push her up to 34 weeks and deliver. 37. After 34, that is severe preeclampsia I'm talking about. Mild, we have to try and deliver up to 37, but that also after each assessing the each organ periodically.
Absolutely. So if this is a reasonably what we call as within inverted commas normal patient and a gestational hypertension, we can try to take her to term provided they are willing for a close surveillance. Yes, now this data has come from the Habitat trial. But if there are any problems or if she goes in for preeclampsia, definitely no waiting.
So one more thing, if we have the facility to do placental growth factor and all, if we have that and if they are very low, then we need to deliver them early. We in those patients, if we continue with this placental growth factor or VEGF is less, then definitely these people will end up in either eclampsia or abruptia or one or the other problems. So these are some of the predictors, but I don't know, many of them is routinely not done. But if we can have the facility, we can do and think who can end up in problem.
Absolutely. Biomarkers are a boon to help us decide in these cases as to whether should we wait or go ahead and deliver. Now, Dr. Azam, this particular patient was an IVF conception, with a history of infertility and gestational hypertension. I decided to do a C-section on her. What is the choice of anesthesia?
Sir, yeah. Now, based on my platelet count, anyway, we have already done so many tests. You have seen the platelet counts and other relevant investigations. And I'm sure she has not thrown a seizure. And even if she has thrown a seizure, if she's very conscious after 1 hour and she oriented, I'd still go ahead with the spinal anesthesia. My first choice is regional, sir, because we all know the preeclampsia who has come for a PAC cleaning, who has a Malampati of grade 1, can get in no time become PAC grade 4, where the difficult airway is so difficult. So my still choice of anesthesia would be regional, sir.
Yeah, great. Okay. Now the next is a little tricky question to Dr. Vimal Kumar.
Yes, sir.
There's always a confusion whether this is a gestational hypertension or whether it is a preeclampsia without severe features.
Yeah.
So how do you differentiate them?
Sir, whether it is just a nomenclature doesn't make any difference. There is then an understanding that all patients should be treated as if they are preeclampsia. And suppose if there is no proteinuria, we should simply label it as atypical preeclampsia. Ultimately, we are interested in the development of avoiding the maternal complications. So just you should not make any nomenclature difference between gestational hypertension or preeclampsia. So in that way, all patients should be viewed suspiciously and don't make any difference between gestational hypertension and severe preeclampsia.
Absolutely. So both are extended spectrum of each other. It could be a gestational hypertension becoming tomorrow severe preeclampsia, or a preeclampsia at least, or it could be a preeclampsia which is not having proteinuria, the atypical variety. But what is important is that 50% of these women will eventually become preeclamptic. And the risk of long-term cardiac issues. Now we are not looking at delivery. Once upon a time, we thought that we deliver a patient, preeclampsia is over. We know that is no longer true. So the long-term cardiac issues is similar in both these groups.
Exactly.
So we cannot ignore a patient with gestational hypertension. I have to bring the point here because I get a lot of referrals in my practice, and people tend to treat 140/90 as if it is of no consequence. So let us all learn at least this lesson that any hypertension during pregnancy is of consequence, and you need to be intensely careful with her.
Yes, sir. Even can I add a point? Even with gestational hypertension, we have seen patients going in for pulmonary edema and peripartum cardiomyopathy, even without proteinuria being present.
Risks are similar, no change. Okay, with this, we go to another case. She was a 28-year-old primipara, married only for 1 year, spontaneous conception. She was referred to me in a post-LSCS status 18 hours with oliguria in a semi-conscious, disoriented state with history of multiple convulsions, decreased urine output, and uncontrolled hypertension. A middle-class, educated lady. She was a teacher, well-cooked, with regular antenatal care. About 10 ultrasound scans were done during pregnancy for her. No significant past history. On date, she was 37 weeks. She had swelling of legs and hands since 1 month, legs and hands since 1 month, and history of weight gain of 8 kgs in 40 days. Scan showed a cephalic presentation at 34 weeks from LLP showing 32 weeks, about 2 weeks growth lag. And the actual interval growth was lagging behind only by 1 week. And there was a mild oligamnios with an A5 of 8. Patient was regularly followed. Then one in the hospital where she was being treated, one reading of BP 10 days prior to admission became 140/90. Repeat BP 30 minutes later was 120/80. So she was advised regular BP monitoring and sent home. Patient went for a routine checkup after this 10 days when her BP was found to be 150/100 millimeters of mercury. So that was time when a repeat scan was done, and now it showed 2 weeks growth lag. Further 2 weeks growth lag. A total of 4 weeks growth lag it has become. A5 was now within normal limits. What was mild oligamnios is now showing an A5 of 16.8 and weight is 1.9 kgs. Investigations were done. All normal, platelet counts 1,80,000, AST 32, ALT 25, urine albumin was 3+. So she was now admitted and underwent emergency LSCS late in the evening, and the indication given in that hospital was preeclampsia and IUGR. She delivered a live female baby of 1.8 kg, good APGAR, and baby was stable. BP in the post-operative period was 170/130 millimeters of mercury. Magnesium sulfate and nitroglycerin drip was given for blood pressure control. Blood pressure continued to remain high. The idea there was that the patient has delivered. We don't have to worry too much about blood pressure. Anyway, I'm giving the nitroglycerin drip. And her blood pressure continued to remain high. And next morning, patient had an episode of convulsion at 8 a.m. Investigations were repeated. And now it was found that the platelet count is 1 lakh. INR was 1.1. Serum creatinine 1.1. After that, she had 3 more episodes of convulsions. And now the mayhem broke loose. She was given all kinds of drugs, phenytoin, 1000 milligram at 9 a.m., 200 milligram at 2:30 p.m., injection phenobarbital at 200 milligram at 5 p.m. Now, these are the real cases, and this is how I've seen many patients being monitored. That is why I want our experts to tell how they would have managed and what has gone wrong here. Now, BP continued to remain high, 190, 120, in spite of NTG drip. So she was now treated with clonidine, 100 microgram oral, and injection Phenergan was given. Urine output was reduced. It was only 200 ml from 6 a.m. to 2 p.m. So the injection magnesium sulfate was stopped because they were worried about giving magnesium sulfate. Urine output in the next 3 hours was 150 ml, and the serum creat, which was 1.1 at 2 p.m., now increased to 1.3 milligram at 5 p.m. So now the question comes to Dr. Kasturi Donimat.
Yes, sir.
This particular patient has presented with a mild rise in BP. She was monitored. It was not that she was not monitored, but she had a catastrophe. How would you monitor this patient? And what is your opinion about the antihypertensives and the anticonvulsants that were used?
So first of all, this preeclampsia syndrome, it's not the BP which tells the severity, it's the other organs which are affected. So irrespective of the BP, whether it is 140/90 or 160/100, all the prognosis depends on how all other organs are affected. So here, her BP was 140/90 and they have sent her home, the 120/80 means where they are reassessed after 15 minutes. So there, if they're clearly monitored and intervened early, maybe all these complications would have reduced. But maybe she had already, all other organ dysfunction has started when it was shown as 140/90 in the initial stage. So more rigorous management when they first identified 140/90, assessing all the organs, how much they are affected by investigations, maybe would have saved this patient from going for such complications. The first visit, rigorous assessment.
The moment the BP is high, even though it is preeclampsia, I tend to call the physician. And we forget that the physician knows how to manage a preeclampsia much lesser than what we know how to manage a preeclampsia. And a cocktail of drugs is given to the patient. So what do you think about she received clonidine, she received Phenergan, she received all kinds of drugs. Even I don't know if I mentioned that, but she had received Lasix because the urine output was low. And then she received magnesium sulfate, phenobarbital, phenytoin. What do you think of this cocktail?
Yes, she must have ended up in intracranial either bleed or first initially edema, then bleed or infarct, who knows, with so much of convulsion in spite of so many anticonvulsants and all, because her BP was also rising in spite. And they're not used routine drugs like labetalol intravenous. They're directly used for, I think, nitroglycerin. Yes.
Absolutely.
Can I add, sir?
The blood pressure.
Usually we start with labetalol, sir. Hydrolenase is not easily available, so we start with labetalol.
Sir, I want to make comment about this case. Hello?
Yes, sir. Yes, Virendra.
Sir, actually, we from our UG days and PG days, we are aware that preeclampsia is a triad of hypertension, proteinuria, and edema. Okay, so we forget to mention that sometimes we may have a case where patient does not have proteinuria, does not have hypertension, but she is bloated up. Such patient should not be neglected because anytime she can enter the spectrum of hypertensive disorders of pregnancy. And in this case, there is also IUGR when she was visited once. And we should remember that IUGR and preeclampsia both are placental disorders which actually share common metabolomics. There's a new word, just like we call economics. It is also metabolomics. So in this case, probably we should have intervened early rather than waiting for another 10 to 15 days. So these two things, like even though patient does not have proteinuria, does not have a hypertension, but severely bloated up, it shows that underlying endothelial dysfunction is catching up. And they may go for severe complications later.
Yes, sir. The presence of IUGR and oligohydramnios.
When I was a postgraduate, the preeclampsia was a very simple disease.
Yes.
Hypertension, edema, proteinuria. That is preeclampsia. I said, now you guys have to learn a lot more things.
Yes.
Because preeclampsia is not what we were defining as before.
Yes, sir. As Dr. Virendra told, any baby with IGR and oligo, it means that there is end organ dysfunction at the placental level. It may similarly occur in other organs. So early intervention we should plan in this preeclampsia patients.
Yes.
Whoever has this oligo
Any
and
abnormal patient, we should label them as atypical preeclampsia,
yes,
even though they don't have hypertension.
We should never forget that.
Yes.
And in spite of the MACPI trial now, which is 20 years old, people still don't know how to use magnesium sulfate.
Yes.
Please use magnesium sulfate properly and keep a magnesium sulfate chart. I have a very simple chart in my department where we put it for all the patients. Use a simple chart and you don't have to worry about using magnesium sulfate. So the pearl that we get from this particular patient is quite often when the patient is delivered, everybody relaxes and are not aggressive enough as it happened in this patient, and peaks of blood pressure are ignored. We need to be definitely not miss such a thing. The next question to Dr. Azam. Now this patient has got all kinds of things happening to her. Urine output is a little less, creatinine going up mildly. What is the role of fluid balance and how will you do the fluid balance?
Yes, sir. So now we have 3 stages. Like, okay, we are talking about fluid management. Why are we talking? Because patient can get into risk of pulmonary edema. We all know about that. And these mothers have something called as leaky syndrome. They are just leaking everywhere because of the low oncotic pressure. I also, where you mentioned, sir, the albumin globulin ratio is almost 1:1. That itself is a very main concern to me, because there are a lot of drugs that bind to albumin. If a drug has to work in a mother that we are giving, there should be albumin in the body, but she's losing out in her urine. That is the other reason why sometimes it may not work. And we also discussed about the left ventricular dysfunction, and the mothers, these group of mothers will also have contracted volume. So how do we manage this case? Simple. Now, if you go by Joy et al., who is in 2019, what they said is, you give a boluses about 200 to 500 ml of crystalloids. I think that is what we do in our institute, sir. And we infuse it not very rapidly, at least over 20 minutes. We see the response, how the fluid response or the urine output is good. If there is no response with the initial fluid management, though the role of CVP is not much indicated as of now, but if you take forward, like many centers, we still use CVP. I mean, people are using CVP even now. Yes, sir. So how do we correlate? So what they say is the volume expansion of about CVP of about, say, 6 to 8 millimeters of mercury is considered to be safe, right? Now, if you have to correlate with the pulmonary artery pressures, which are much more accurate to say whether this patient can get into pulmonary edema or not. So a CVP of 8 millimeters of mercury corresponds to a pulmonary capillary bed pressure of 18. So our aim is to keep the CVP 8. But however, in these cases, what we can usually do is we can have a little lower CVP, say about 4 to 5 millimeters of mercury, where we have an additional 4 millimeters of mercury to give us some kind of fluid challenges for this mother. So if I was to be an anesthetist in this case, what I would do is I take the fluid balance, in the sense the input versus the urine output, and I estimate what are my insensible losses. So usually I start a maintenance of about 300 to 50 ml after giving this fluid challenges and see how she does. The other thing, what we also discussed was, sir, you said magnesium sulfate was stopped. Correct? Somewhere they had stopped magnesium sulfate. The easiest way I would do is just see a deep tendon reflex loss. If it is not happening, I would consider that this because we all know that magnesium sulfate is the drug of choice. So my still fluid of challenge would be giving about 200 mils to 300, not more than 300 mils. Now, what happens if the patient get into oliguria? There is a chances. Now we know that patient is having so many problems. We have given a little bit of fluid challenges. Now oliguria is happening after giving even 300 mils of crystalloids. So oliguria could be pre-renal, renal, or it could be both. So about additional you can consider giving, but with very cautious, because they get into pulmonary edema. And if it does not respond, I think the first thing we need to keep in mind is about the renals. So this would be my fluid management.
Yeah, absolutely. One thing we should never forget is, if you give too little fluid, there's going to be a renal injury. You give too much fluid, there is going to be a pulmonary edema. So balance that very well.
Yes, sir. Can I make a comment, sir? Just one sentence.
Yeah.
But before giving antihypertensive, because such patients are likely to receive parenteral antihypertensives, before giving parenteral hypertension, one should see that intravascular volume is actually adequate, because all these patients have already got contracted intravascular volume. On the top of that, if you give parenteral antihypertensives, there is going to be renal injury.
Absolutely.
So that is one. And number two, some of us are still in the habit of using diclofenac as an analgesic post LSCS, because use of NSAIDs in a precarious condition can cause renal injury also. So choice could be probably epidural analgesia or you can use contromol.
If your patient is hypertensive, do not use diclofenac.
Yes.
Do not. Keep her pain-free with whatever else you want, but don't give her diclofenac.
Yes, sir.
Totally agree with you, sir. Yes. Yes. We
Okay,
don't know how much it is affected.
Dr. Azam again. See, in any other patient, if they lose 400, 500 ml, we are not worried. But if a pre-eclamptic patient loses about 400 ml, we worry. Why?
Yeah, that's what, sir. Now, whenever there is a blood loss, we say, have you given, oxytocin or whatever drugs? So, these group of patients can tolerate, don't tolerate blood loss to a maximum. As such, their intravascular volume is contracted. That is one. Second, they have hemoconcentration. And I think, the drugs that we give, like as you have mentioned here, ergometrin. I mean, it's a big no, but we need to keep in mind that it can induces what you call hypervolemia. That is what we are main concern about blood loss in this group of patients.
Absolutely. So remember, do not allow your patient to go in even for a mild PPH, because that could tilt the balance in the wrong direction. And one more question when we talk of PPH, please do not give ergometrin. I'm sure you have heard this before, but invariably I get patients who have received ergometrin and thrown a convulsion. So don't give ergometrin to these patients. So because the patient continued to have severe hypertension, convulsions, and decreased urine output, she was referred to my maternal fetal medicine unit for tertiary care and further management. Now, this goes to Shruti. We have about 10 minutes, right? Anu, we have about 10 minutes?
Yes, sir. Yes, sir.
Okay. So now you're...
Sir, Prakash Mehta, sir, can I just add a small thing?
Yeah.
Now, we said there's a bleeding, right? Now, as you know, these patients will have about thrombocytopenia, low platelet count. Now, I think the take-home message also should be, because nowadays our medical legal cases are also increasing. The documented recent value should be at least 1 to 3 hours, not more than that. That is one. And there should be a trend in the platelet count, which is much more important, which can document your bleeding that is ongoing. Right, sir. Sorry, sir.
Shruti, the question to you. Now this patient was being transferred. What steps will you take for transferring?
As any emergency care, airway, breathing and circulation to be maintained. And also the hospital where we are going to refer should be alert that such a patient is being shifted. So they are ready with all the emergency care that has to be needed. Because once we shift the person to the hospital and they say we have no beds available or anything, again shifting them to another place would be a problem. So first and foremost, connect with the hospital to which we are referring and make sure they have all the facilities there, because that's a dead-end hospital which they're going. They can't get referred again and again. And all the support teams to be alerted, like the neonatal team, the anesthesia team, and the blood units, whatever is required, should be before kept in hand. The patients also, most importantly, counseling of the patient attenders for the worst outcome possible is a must, because this will prevent, on the way when we are transferring, if a death happens or anything, we have to explain to the attenders before in advance about the possible complications of both maternal and the baby, and during the transit, what complications can happen, so that in the midway we are not beaten up. That is the other things we have to take care. And also Maxelf and all the emergency drugs should be ready in the transit system. And yes.
Fine. And make sure that the drugs that you have given, you have a full list of the drugs.
Yes, that's more important. Yes.
I need to know how much more magnesium sulfate I need to give to her. When
yes,
do you stop magnesium sulfate?
Be in contact with the referring hospital to update about the patient list.
So the patient was shifted to our ICU and ventilated, restarted on full dose of magnesium sulfate. Now that she was ventilated, I was not worried about respiratory paralysis anyway. So we started her on full dose of magnesium sulfate, and we started her on metoprolol because she had a tachycardia. And platelets and FFP transfusion had to be given because the platelets had dropped further. And of course, multidisciplinary care, as Shruti said, we need to have all teams ready. It was instituted, and ultimately we diagnosed it as PRES, posterior reversible encephalopathy syndrome, which has come in because of uncontrolled hypertension for a long time. And once after that, she had no further convulsions. Her blood pressure stabilized. Magnesium sulfate infusion stopped for 24 hours because it was more than 8 hours. The magnesium sulfate had been stopped. So I took it as 0 hour from the time I restarted the magnesium sulfate. Of course, we did measure, because her creatinine was high, we did measure the magnesium sulfate magnesium levels, which was about, I think, 2.4 or 2.5 only. So we could continue giving her magnesium sulfate. Patient was extubated on day 2 as there was no more convulsions and spontaneous efforts at breathing were present. Patient became oriented after 72 hours, blood pressure was well controlled, and then the investigation report started trending towards normalization. Totally, I had to give her 21 transfusions of both blood and blood products together. So the most important lesson to learn from such a case is, even though HELLP syndrome is considered to be a variant form of severe preeclampsia, its severity is reflected in its laboratory parameters and not in the use of clinical parameters of blood pressure and proteinuria that typically reflect the preeclampsia disease reality. And remember that HELLP can present for the first time after delivery in a normotensive patient, and it could just start as a massive postpartum hemorrhage. So you have a postpartum hemorrhage, you have a convulsion in a so-called normotensive patient after delivery. Keep HELLP syndrome in mind.
Yes, sir.
Of course, this is important. This is an important pearl which I've already told, but I'm going to repeat. Preeclampsia has been erroneously considered a transient condition, and we believe that once a pregnant woman has delivered, she's fine. Remember, truth is that often she is not fine even after delivery. So don't give up your intense monitoring on this patient. Now, since we have been talking about long-term effects, Dr. Virendra Kumar, could you quickly tell us what are the long-term effects of PE?
Yes, sir. Basically, preeclampsia is a metabolic disease which is probably unmasked during pregnancy, and better to view it as a latent cardiovascular disease. If you remember this, definitely we can predict. These are the patients who are twice likely to develop hypertension later compared to those who are not hypertensive. They are also candidate for developing cardiovascular disease. They are at risk of developing cerebrovascular accidents like stroke, and they are also prone for development of myocardial infarction and renal disease. See, these patients should never be forgotten that they only transient disease, and they need a lifelong follow-up for development of these complications.
Absolutely. So please do not forget your preeclamptic patients when they deliver. You need to follow it up. And also remember, the fetus is also at risk because this fetus has gone through, when you think of Barker hypothesis, this fetus has been deprived in utero. So when it comes out, it is also going to show long-term effects. So both mother and fetus are going to have long-term effects. Do not forget your patient. Please follow them up thoroughly.
And many of these patients have dyslipidemia, sir. Probably it may be a prudent practice to go for lipid profile of such patients.
Absolutely. So remember some basic rules. Do not attempt to normalize the BP drastically because rapidly lowering the BP is associated with maternal and fetal and neonatal morbidity. And remember that these patients have a rightward shift of the renal, cerebral, coronary and placental pressures and flow autoregulation, and rapid decrease in BP will cause a marked decrease in the blood flow of all these organs. So be gradual. Remember, we are obstetricians. We are supposed to be highly patient. Isn't it? We are the most patient people on this earth, standing before perineum for hours together. So you can stand for a few minutes in front of a hypertensive patient and bring down her BP a little slowly. No diuretics before delivery. She's intravascularly depleted and you will cause more organ malperfusion if you give her diuretic. You definitely have to give diuretics after delivery because pulmonary edema is very common after delivery. So watch out for it and give a diuretics. Now, do not give diazepam to stop an eclamptic seizure because the rapid administration of diazepam at that stage is going to produce apnea and facilitate aspiration. So be careful about it. When a patient throws a second convulsion, third convulsion, everybody is thoroughly disturbed and you give whatever you have in hand. So try to avoid it. Give her another 2 grams of magnesium sulfate. She will definitely settle down. Only 20% of the patient will have convulsions on magnesium sulfate, and of that, hardly 2 or 3% will convulse in spite of a second dose of magnesium sulfate. I'm sure you agree with me, Dr. Virendra Kumar.
Yes, sir.
So in conclusion, remember both maternal and fetal life is at risk. Multiple issues, balancing act is very important. Multidisciplinary approach, early transfer. Do not hold on to the patient. If your center is not capable of managing the patient, please don't hold on to it. You will thank me one day if you remember this sentence because litigations are very common in these patients with preeclampsia. And we need to educate the community at every opportunity we get so that late presentations are prevented. And the stellar role of biomarkers is always there. I wish more and more of us make use of biomarkers. It's more easily available, even in the smallest of the towns, because biomarkers is one entity that could make our life very, very easy. So thank you all very much. And I thank my panelists for giving us a wonderful discussion. Dr. Virendra Kumar, Dr. Kasturi, Dr. Shruti, Dr. Azam, thank you very much for being there. All of you are very busy people. Sunday is the only day you have time to spend with your family and you spent it with us. Thank you very much for it.
Thank you, sir.
Thank you, sir.
Thank you very much,
Thank
sir.
you, sir.
Thank you, sir, and all the panelists, not just for the wonderful discussion that we had, but also to wind it up on time. Thank you so much. Almost always the panel discussion goes way ahead, and then the time controlling becomes a little bit of an issue. And it was so nice to hear you all talk about preeclampsia and the management of it. Next on line, I would like to invite Dr. Revati Rajan. Dr. Revati is our secretary of SFMI and the co-chair for PENAI program. Dr. Revati would be talking to us about making of PENAI, and also she would be giving us a gist of the iShip conference, which is going to come to Bangalore in 2023. Over to you, Dr. Revati.
Good morning to everybody. And I'm so glad that I have this opportunity to be talking about the pre-eclampsia education of the nation, India, which is considered to be the flagship project of the Society for Maternal Fetal Medicine, India. The whole VLSP program has been planned to build awareness in and around the PENAI program. And I'm so glad that we had this valuable capsule on antihypertensives and also the clinical discussion about management of hypertensive pregnancies in such a comprehensive way. So with this background, I move on to the core concept, which is the preeclampsia education of the nation, India. Now, what is this preeclampsia education of the nation, India, in short, PENAI? It's a certification course for practicing obstetricians and gynecologists in India. And this uses virtual-based information on hypertensive disorders in pregnancy. And most importantly, it's a collaborative project by the Society for Maternal Fetal Medicine India, as well as the International Society for the Study of Hypertension in Pregnancy. Now, most importantly, I would want to say that this is one of the only projects maybe in the world which uses modules for formal training on hypertensive disorders in pregnancy for practicing consultants, not just obstetrician and gynecologists, because we also want to target all physicians who are in touch with managing hypertensive pregnant women. Now, just to introduce about the project, the Indian co-chairs are Dr. Prakash Mehta, sir, who is the president of the Society for Maternal Fetal Medicine India, and of course myself, who is also the secretary for the Society for Maternal Fetal Medicine India. Dr. Sarosh Rana is the international co-chair, and she is also the international advisor for the Society for Maternal Fetal Medicine India. This has been a lot of hard work for the past maybe 2.5 years when the idea started on email, and today we are at a stage where we are actually educating, or we are certifying a lot of clinicians who themselves are empowering, with evidence-based information to treat pregnant women, to make a difference to their lives as well as the lives of their unborn. Now, why did we actually choose to make this course? Before I move forward, I want to tell you that we had the privilege of presenting the excerpts of what we have done till date at the recent International Society of Study of Hypertension in Pregnancy conference. I was supposed to be going there in person, but because of certain visa issues, I was not able to make it. But I'm really glad that Dr. Sarosh Rana, who has been the international co-chair, presented on our behalf, and it was really applauded by a global audience. Now, with this background, we want to tell you the excerpts of this particular presentation is from what we presented at the International Society of Study of Hypertension in Pregnancy. Now, preeclampsia is one of the 3 leading causes of maternal morbidity and mortality in India after hemorrhage and infection, something that we have to really consider at this stage. There is no clarity about guidelines, classification systems, management protocols for HTP, and with particular emphasis to preeclampsia. Atypical presentations are so common, making management so complex. Implementation issues in urban and rural settings differ. Challenges exist in extrapolating global research and guidelines into the indigenous population. It's not that we can't do it, we have to do it the right way. There is a felt need to source and compile clinical research protocols relevant to the Indian practice that needs to be addressed. Very, very important for us to Indianize what is really required to save our women from the complications of preeclampsia. The supports, this was the whole idea. It started off with India, but let me tell you, we've already started registering international delegates. We want to go beyond our country to reach out to the rest of the world, along with the International Society of Study of Hypertension Pregnancy, to make this a norm and not just a need. So we want everybody to be certifying through the course. Our supports, we are really thankful to Roche India, who supported us by a financial grant for the pilot project. Of course, the SMF, my office staff, Shrikant, Dr. Meghna Srinath, as well as Raj Gopal, who really worked hard to get this project on board. And of course, Medinet, who have been our knowledge and hosting partners. And we are really grateful to Shield for helping us to propagate this course through the VLSP program, of which today is the 3rd in series. And how did it start? We started with an email. We started coordinating with faculty from across India through the PENAI project implementation meetings. They were just meetings that were held every week they were all virtual during the COVID times, and we literally brainstormed on what was relevant and how we could improve the quality of the course. The office was involved in collation of MOUs, documents, creation of the PENAI helpline, and there was also a lot of collaborative efforts. We united a lot of people to get on board so that this course moves very robustly. How did we design the modules? Basically, these are all learning modules which are on a virtual format. So we put in collaborative efforts with emphasis on translational research. So we wanted to look at guidelines which could be used for everyday practice. We wanted to make it as clinician friendly as possible. And we wanted to make it as comprehensive as it could get with all the evidence-based information. And believe me, every module has these concepts. in place, and we plan to update it very, on a regular basis. Maybe after a few months, this course will get updated again. Now, this is a very precious slide. I have all the people who have actually contributed to this course on a single slide, and that's a difficult task, let me tell you. We have the world's best, and who have actually contributed to teaching. We have Dr. Sarosh Rana, who herself has contributed topics on the biomarkers as well as management of postpartum hypertension. We have Prakash Mehta sir, who's actually talked about all the clinical situations in a very valuable panel format, which probably emphasizes on how we have to manage hypertensive disorders in pregnancy. I myself have looked at the Indian basis of the biomarkers through the robust study. We have other renowned faculty like Dr. Laura Maggie, who's contributed on the PIRES and the PrEP model. We have Dr. Leona Poon, who's actually contributed on the Aspirate trial. We have Dr. Sanjay Gupte. We have Dr. Girija Wagh. We have Dr. Suchitra Pandit. We have the entire SMFMI group lined up who've actually contributed a lot, which has covered end to end on preeclampsia. So starting from the definitions to the etiopathogenesis, going to the management, and the most recent aspects, evidence-based information on the preeclampsia has been covered as a 6-module course. Now, with this background, let me talk to you about the implementational salient points. We launched this course as a modular course on the 22nd May of 2021 on the World Preeclampsia Day. And this is definitely a very novel project because let me tell you, there is no program that exists in the world for formal education to providers regarding preeclampsia, which aims at empowering clinicians all over the country and beyond. Our current target audience is definitely full-time working professionals, and most of them or all of them have been obstetrician gynecologists, though we want to really educate the grassroots level clinicians very soon. We face some challenges because after propagation and after the clinicians have agreed to the course, getting into the course, enrolling into them and finishing the course and taking the assessment was a big challenge that the office faced. But we did not give up. We have followed literally every delegate till the end point. And we have a few delegates who will tell you about how the course went and how they feel empowered at the end of the course. Now, to understand how it works, every registered candidate has 6 weeks of full-time access to the course. The candidates can watch the pre-recorded lecture videos any number of times at their convenience when they're registered. The lectures were designed by renowned faculty in the country and in the world who have done exceptional work in the field of preeclampsia. Some candidates, however, could not finish the course in the given period. Upon request communicated on email, we have given them extension of the complete course, which is something that I want to emphasize because ultimately we want many people to complete the course in the real way to feel empowered. The SMFMI office has motivated candidates to finish the course on time and has constantly been in touch with the candidates. After completing the course and the lecture videos, the candidates must take an online assessment, which is a 60-minute assessment of 2 categories. One is the objective-based test and the other is the clinical case-based comprehensive test. The OBT consists of multiple choice questions with 1 correct answer. And definitely the clinical case-based comprehensive test is again on a multiple choice-based questions, but on real case scenarios. At the end of it, we give what is called the Pearls of Wisdom, which is a downloadable, concise booklet compiled to help candidates with future reference. So ultimately, the candidates can keep this as a ready reckoner reference, and they can definitely contact any of the faculty over email, which will be coordinated by the office as well as the Medinet team, so that they can get direct answers, because we've been answering their questions day in and day out about the course as well as their clinical problems. The assessment and certification process has been very vigorous till now to assure the standard of the course is well maintained, and the candidates have, some of them have dropped out of the course, but there have been very few people who have actually dropped out of the course. Candidates who fail in both attempts are required to re-register for the course, and the main reason for dropout has been a lack of finishing the course within 6 months. But definitely this has prompted the SMFMI to come up with the idea of a 1-day on-site mass enrollment program, which we plan to do with the Mysore team very soon, where we want to register at least about 50 delegates who are interested, and maybe those who cannot look at learning over a period of 6 weeks can do it on one single day, join the course, finish all the modules online, take the assessment, and get certified on a single day, and then stay in touch with us for further queries. Now, these are some of the images. These are, this is reflecting a lot of hard work, dedication, and perseverance. These are how the Penai project implementation meetings happened online. There were several of these meetings, I think about 10 or 11 of these meetings. And then the virtual learning series on preeclampsia, which is taking this course across the country. Now, these are very precious to us because this is our first milestone of a first set of passed out delegates. We've had a virtual convocation where we've actually given them the certificates. And the best part of it is they were a part of a live interactive session, which was answered by the global co-chair, Dr. Sarosh Rana, as well as the Indian co-chairs, Dr. Prakash Mehta and myself, to actually deal with their clinical problems. And then they were actually given the certificate. The provisional certificate looks like this. So you would get a provisional certificate before completion of your virtual interactive session, which is the final point of completion. And then you would be given a final certificate, which could probably tell you that you have completely finished the course, and maybe you will be intimated whenever the next update happens. Now, moving ahead, the assessments was a challenging task because we expected the delegates to score at least 75% to call themselves certified. This was as per the recommendations of the International Society of Study of Hypertension in Pregnancy. We did face certain issues when the delegates, just could not manage it maybe by a few marks or percentages. Then we had a provision for a Viva Voce, which we diligently conducted to ask them clinically relevant questions, which covered all the guidelines. And I'm so glad that all the delegates were able to do this very efficiently, and they've been part of our, they have after completing the course, they have been our ambassadors to actually propagate the course across the country. Now, this is how the Penai Pearls of Wisdom looks, which is the downloadable version of all the content, which is given to all delegates. Now, this is how the feedback form looks. We have a big feedback, which has all the relevant information about what the delegate feels, not just about the course, about the different guidelines, the faculty, the hosting partner, because ultimately this is going to give us a foundation of how we are probably going to spread the message of preeclampsia awareness across the world. Now, statistics, we have 1 or 2 fully registered delegates. It's not an easy number, let me tell you, because motivating the delegate, making them understand about the course, making them pursue the course, and helping them reach the assessment mark has been the most difficult task. But I'm really happy that out of 250, which is the pilot target, we've already reached 102. And 14 people have completed the live interactive session. There are 25 more who are supposed to be doing it. And we're very happy that we have 9 people from Bangladesh who are already going to be registered, who have already registered to the course. And so Penai has actually crossed the geographical borders. Now, future of the course, we want to navigate beyond the pilot to reach out to all the practicing clinicians across the country and beyond through collaborations, which we are doing. We are very happy that every time there is a VLSPE series, we are collaborating with a new society, building up a chapter of the Society for Maternal Fetal Medicine India, which is taking this flagship project across the country. We want to reach out to SAARC countries, which we have already done. We want to reach out to the Africas and the South Americas, which has been our top priorities, which we want to do it during this year. We want to do periodic module updates, which we will do very shortly. We want to empower clinicians with the latest evidence-based information and research on preeclampsia, which we're doing it with every candidate. Extrapolation to the grassroots level clinicians, we want to try it out in Bangalore. We want to do it to the corporation level doctors. We want to reach out to global organizations for extended support, which is in the mind, and to support preeclampsia research in the future, which will enhance quality of care in the country. And These are our, you can find it when you type the Preeclampsia Education of the Nation India or the SMFMI, you will find these links and you can actually see all that we have done till date on the YouTube. And these are our correspondence details. You can also see the helpline here, the office number 95914655757. You can contact us anytime between 12 p.m. and 4 p.m. and we will be ready to help, though the helpline is working almost like 24 hours to get in touch with the delegates. And thank you so much. And Anu, before we actually move on to the iShip World Congress, or should I just finish off the presentation and then we can call Dr. Gayatri, who is ready to actually tell us about her experience? Shall I ask Sahiti Priya to finish off the iShip World Congress and then we can call the Penai delegates?
Yes,
So that it's a continuum.
Yes.
So we're really glad that this is the flagship project of the Society for Maternal Fetal Medicine India. And this has reached out to globally through the iShip World Congress 2022, which happened recently at Montpellier in France. And we are really glad, and I, on behalf of the Society for Maternal Fetal Medicine India, would want to tell you that the iShip 2023 World Congress is going to come to India, and it is going to be scheduled in Bengaluru. So this is a small snippet introductory video which was inaugurated at Montpellier in France. So I invite all of you to be part of this countdown, and then I will tell you one or two lines after this video. Please watch this So this was the introductory promo that we actually inaugurated at the Montpellier iShip World Congress 2022 in France. You can hear the national song Vande Mataram, which is playing in the background. It's a dream come true opportunity, as well as an academic feast for all of us. And you will see all the world's best faculty who will be talking 4 days of dedicated discussions, making talks on hypertensive disorders in pregnancy. And we welcome all of you to register. We will share the details very soon. You can do a pre-registration, which will probably tell us about your interest about registration to the course, and we will follow it up over emails to register you as soon as possible. So with this, I invite Dr. Gayatri, who has been one of our, what should I say, a very active, as well as a delegate who actually passed out recently, and she would probably share her experience about the entire course. Dr. Gayatri, please take over.
Hello, good morning. Am I audible?
Yes.
Yeah. So at the outset, I would like to thank Penai for giving me this opportunity to enroll myself in this educational endeavor. For me, preeclampsia has been very close to my heart for several reasons. Over the years, we have noticed that preeclampsia has always attacked us before we have anticipated events. And I think as obstetricians, it's very important to preempt the situation and catch preeclampsia before it catches us. I think most often we have noticed that we have miss the bus after delivery. As long as a woman is pregnant, we are very vigilant with blood pressures. And after delivery, there's a bit of a complacency which sets in, I think subconsciously, which is what we all need to understand to be alert and on the guard. And Penai has enlightened us as who are the cohort of patients we need to be alert. And that's something I think I learned from the Penai. And the other important message, I think, which Penai is doing a very good job is about the usage of ecosprin, the precise usage of ecosprin. In the present day, we see obstetricians giving ecosprin like folic acid. And I think we need to decide and individualize care and give ecosprin to the right people. And that is when I think the message goes on well, saying that ecosprin is here to prevent preeclampsia, at least to a good 60% of women, if given at the right time, in the right dose. And I think it's also important as healthcare providers that we educate our patients regarding the possibility of preeclampsia in a primary gravid woman. Even before she lands up with a bad obstetric history, I think if we have achieved educating all our primaries who are at risk for preeclampsia, who are identified by the 12th week, I think it's a good lesson, and we are here to achieve our reduction in maternal mortality. Recently, I had a patient who had a 12th week scan which said high risk for preeclampsia. She was started on ecosprin. She was just told to be vigilant about her blood pressure. She was also given double 2 grams of calcium as recommended. And then her pregnancy was going very smooth. Yes, her uterus was laden with fibroids, fully stretched on the lower uterine segment. That was a concern for me that she should not be coming in an emergency. And then I had just started on ecosprin thinking that maybe she may not be the candidate to get into preeclampsia. And she comes back to me at 28th week saying her BP reading is 140/90 and she's got swelling. And she comes to us ourselves because we have educated her. And then we did the ratio, and the ratio was all over the place, but her blood pressures were just 130/80, 140/90. She was told about the possibility of getting into trouble. And dead of the night, she was in the hospital because the ratio was a little too beyond the picture. And in the hospital, dead of the night, we had an abruption with a transverse line. And I think the ratio saved us that she was in the hospital. So I think very important messages given by Penai. I'm grateful for having been in the program, and I have instigated all my residents to get enrolled for this program. I thank Dr. Prakash Mehta, Dr. Sarosh Rana, Dr. Revati Rajan for all the pearls of wisdom that I truly learned. And I thank Medinet for an excellent, platform for learning. Thank you so very much.
Thank you so much, Gayatri. Sir, if you could just share a few words before I show the poster as to how it actually looked at the iShip World Congress. It'll be
you can show the poster now. Show the poster.
Sure.
Now, Dr. Revati will show you the poster on Penai, which was presented in France, and now the ISSHP has taken it up as their flagship project. So basically just one look at the poster, which was presented in France.
Just a minute, sir. Yes, here we are. And I think I presented exactly what the poster.
Yeah, it's quite a heavy poster, that's why.
So basically, I also had the slide format. And I think all the delegates were informed about the Penai course. And they have been receiving a lot of good feedback because this is one of its kind course in the world.
Ma'am, slides are not visible, ma'am.
You can stop sharing the screen because it's not going to open. It's very heavy.
No, sir. 1 minute. Did you were not able to see it? Let
No,
me just
it's not
share it
open.
again. Just a minute. I'll share it again.
It's heavy. That's why.
No, sir. Just can you see it now?
Now it's seen.
Now it's seen.
Okay, let me just make it like a big screen. Where did it go? Okay, let me just put it in the same format so that you will see the in this format. Yeah, this is here. Yeah. Okay.
So this poster was appreciated so much in the ISSHP conference of 2022 in France that Dr. Annie has, who's the current president of ISSHP, has taken this as a, like a personal project and would like to take it.
There's a proposition from Dr. Sarosh, sir, that they are really.
Dr. Sarosh is always one of us.
So we welcome all of you to join this and register to the course. And I think it's a journey that all of us want to be empowered to join hands and save lives. Thank you so much.
Thank you. Yes or no?
Hello, Amita. One second.
Hi. So over to the next program now. This is Dr. Sunita's stage now. This is about new chapter formations, new relationships, new people being added to the family of SFMI. Over to you, Dr. Sunita, for announcement and inauguration of the new chapter from Hubli Dharwad.
Yeah, thank you, Dr. Anu. I welcome you all to the inauguration of the chapter of SMFMI, the Hubli Dharwad chapter of SMFMI. We are very happy to proudly announce the third chapter being opened today. We already have the Mysore and the Salem chapter with us, and this is the third chapter which is going to get inaugurated and to be declared open today. So as we come to this program, this is actually a very special program to all of us. Since SMFMI is always about collaborating and to have new members enrolled to our society to ensure that whatever is the vision and the objectives of the society gets spread across the entire world. This is our aim, and we proudly pronounce this chapter open today. First of all, we will have the invocation by Master Aprameya, son of Dr. Revati, to add the new light and to invoke the blessings of Goddess Saraswati. We will have the invocation now.
Saraswati Namostute Sharade Vidyavrade 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 Saraswati
Thank you, Aprameya. Thank you, Aprameya, for your sweet voice to invoke the blessings. Now, to invite the dignitaries, I first call upon Dr. Prakash Mehta, sir, to welcome all the delegates and also the chief guests for our today's inauguration program. Dr. Prakash Mehta, sir.
Yeah, good afternoon again, everybody. I think this is indeed a proud moment for us because we are spreading to the north of Karnataka now. And, I have a young team of people in the committee, and I've given them all an order that every 6 weeks when we have this program, we need one chapter to come in. And my team is keeping that up. We started with Mysore, then with Salem, and now we have come to Hubli Dharwad, and Dr. Kasturi Donimat has been kind enough to make sure that this program spreads across to that part of the state. Our next possible chapters, which we have in the pipeline, would be Aligarh and later would be followed by Lucknow. So with this, I welcome Dr. Kasturi Donimat to our family of SMFMI. Welcome, ma'am, along with your team.
Yes, sir.
Could we have the inauguration now?
Yes, sir.
Congratulations, the Hubli Dharwad chapter of SMFMI.
So thank you. And now, Dr. Kasturi Donimat, I would like to speak a few words.
ಕಬರ್ಡ್ ಸ್ವಲ್ಪ ಆಲ್ಟ್ರೇಷನ್ ಮಾಡಿಸ್ಕೊಂಡು ನಂದು ಬೆಡ್ರೂಮ್ ಕಬರ್ಡ್ ರೀ
Okay. Very pleasant good morning, sir. Good morning to the whole team of Society of Maternal and Fetal Medicine. It's really a very great day for us, for Hubli Dharwad chapter, to join this very, very prestigious Society of Maternal and Fetal Medicine, India chapter. It's a great privilege, sir, and a proud moment. And we are extremely thankful to you for giving us this opportunity. Thank you for selecting Hubli Dharwad team among this in this international and national platform. So we feel highly obliged to you. And I have our whole team here: Dr. Priscilla Thomas, Dr. Rashmi Desai, Dr. Sheetal Kulgod, Dr. Amita Kamath. They are here, sir. I'll introduce one by one. Okay.
Yes, please.
Okay, sir. So I'll be taking over as the president of this Hubli Dharwad chapter, and secretary Dr. Priscilla Thomas, who is the present president of Hubli Dharwad OBGYN Society, and Dr. Rashmi Desai, who is the present secretary of HDOJS, and our core team, who is very, very active, very enthusiastic to work, Dr. Hemlata, who is a professor and unit chief at Department of OBG KIMS, Dr. Amita Kamath. We have Dr. Amita Kamath here. Dr. Amita, yeah. So Dr. Amita Kamath, associate professor, again in the Department of OBG KIMS Hubli. We have Dr. Sheetal Kulgod, consultant at Tattvadarsha Healthcare, so the senior gynecologist. Dr. Sheetal is here. Yeah, Sheetal, you can unmute.
Thank you.
Yeah. And Dr. Rashmi Shelgar, again assistant professor in our department of OBG KIMS Hubli. Dr. Rashmi Desai, yes, you can unmute, Rashmi. Yeah.
Good morning,
Yes,
everybody.
Welcome to the family.
Thank you, sir.
Thank
you, sir. Thank you so much.
And Dr. Asha Nervi, professor and head of the department, STM Medical College. And
And
Dr.
also-
Jamuna Kanakraya.
Yeah.
Dr. Jamuna is here. Yeah. Jamuna Kanakraya, one of another very active member of Hubli Dharwad OBGYN Society, sir. So we all have all of them as our core members for this Society of Maternal and Fetal Medicine. I'm very, very happy to be part of this chapter, sir, because here, especially in our this thing, we see that we are dealing with lots and lots of high-risk cases. So by joining hands with you, we are looking forward to bring down the maternal and fetal morbidity as well as morbidities, better mortality. So especially that Pen I is very, very important, very, very innovative, novel project of yours. I'm sure I'm going to make all our residents, all our staff and the postgraduates and encourage all our Hubli Dharwad members to be a part of it. I saw that poster. It was such an excellent, so much of information. I'm sure I'm not surprised why they were so much inspired and taking that message all over the world. And especially in this part of Karnataka, especially in our college, we see that we have lots and lots of preeclampsia cases. When I go to as MCA inspector to Kerala and all, their eclampsia ward is empty. But in our hospital, our eclampsia ward, on a given day, 3 to 4 cases of eclampsia patients are there. And so many cases, all the complications, all CVT, cerebral bleeds, press, so many at a given time. Every alternate patient is preeclampsia, either anemia or preeclampsia, and thrombocytopenia. Every day, it's a very common problem for us. Anemia, thrombocytopenia, preeclampsia, peripartum. These are very common words for us every day because day in and day out we are dealing with these patients. And all variety of patients, those who come late, those who come very this thing and suddenly end up in problems, catastrophes and all. I think by being a part of this Pen I program, learning from this, I think it is going to be a great learning. And from that, when we put and implement at ground level in our day-to-day practice, in day-to-day management of patients, I think it's really going to bring down the mortality and morbidity of a patient in this area of Karnataka. Especially what I see is we get from Gadag, Koppal belt, lots of preeclampsia. We are trying to analyze why. Is there any problem in the nutrition or the lifestyle, or what is the problem? We keep auditing, self-auditing ourselves. Why is it we are getting like this? So with this, by learning from your this Pen I project, Novel project, I think definitely we'll learn a lot and implement it, and we'll give you the result after implementation also, how much we are able to reduce. So very, very happy to be a part of this. Looking forward for a very enthusiastic and active participation in this. I'm sure Hubli Dharwad team is going to be a very active society chapter for this SFM, Society of Maternal and Fetal Medicine, and lots of learning for us. And thank you once again, sir, for including us. We are looking for more and more learning from you. Thank you.
Thank you very much. Thank you very much, Dr. Kasturi.
One special request, please make sure that people in your department present paper during the
ISSHP conference.
We are doing a lot of work, but we are not projecting it.
Yes, sir.
You know, now, so what happens is the guidelines are given by people who would have seen 10 eclampsias or 12 eclampsias in their entire lifetime.
Yes, sir.
So unless we come out with research, we are not going to reach that level at all. So please encourage them, and this will be a good chance for them. We are keeping a special breakfast session so that there can be a 1:1 interaction with any of the international faculty, and they can have a joint project which could be taken further along.
Yes, sir. I totally agree, sir. What guidelines we have all are international, but their socio-cultural scenario is different. Our socio-cultural is different. So we may have a separate new guidelines for our own people from India, which the whole world can look up to, sir. With your leadership, I think we can go ahead with it.
But once we set, that's why we started with Pen I, so that one day we want to come out with the guidelines for our country, our people, so that it suits everybody.
Yes, sir. So
Yes, sir,
it's
and
going
also
to make
Dr.
a huge
Jyoti-
difference in the society, sir. It's going to
True.
make a huge difference.
Yeah, we all second Dr. Jyotika Desai madam's thought process that Dr. Kasturi Donimat should be involved in research in finding out why the prevalence of preeclampsia is so high in our community, in our state. So it was very nice, Dr. Kasturi and team, to join us today, and we welcome you all to the SMFMI society, to the family. We know that we will be expanding soon, and all will be given responsibilities for the new ISSHP conference, which we'll be having in 2023. So this will be an added responsibility to all the chapter people who will be joining the society.
Yeah, Sunita, to all those who are watching us on the YouTube, because this program is being relayed live on the YouTube, we would definitely like to have chapters everywhere all over India. Our main aim is only that no woman should ever die or suffer because of preeclampsia. So anybody joining hands with us in this endeavor are most welcome. You could contact the office, and definitely we would take it forward. So thank you very much.
Thank you,
So,
sir.
thank you, sir. I now request Dr. Anu Joseph to propose the vote of thanks. Dr. Anu, you are muted. Dr. Anu, you have muted.
Thank you.
Yeah.
Thank you, Dr. Sunita. At the outset, as always, and as ever, I would like to thank our president, our mentor, our teacher, Dr. Prakash Mehta, sir, for always giving us the opportunity, and more than the opportunity, I wouldn't call it the pressure, but the motivation to do more every day, to come out of what is convenient to us, to probably what better we can do about in our profession. So you have been a guiding light, and this we tell at every meeting that we have, and I feel that's not enough, and it should probably go on and go forth every time that we meet. And for having got all of us and still keeping on getting more and more people into this and going forward. Dr. Revati to have been a great right and probably the left hand to Sir, and to being the secretary and being a big time motivator and an exemplary person who organizes things so meticulously. I have always been in awe seeing Dr. Revati handle things left, right, and center, and also managing courses like Penai and for doing programs like the VLS series and everything. Thank you, Dr. Revati, for this. And then coming to all our delegates for today, Dr. Virendra Kumar, Dr. Kasturi, Dr. Azam, Dr. Shruti, and everybody from the Hubli Dharwad Society who have joined us new today. Thank you all for joining in today. All the delegates who have attended the program today, Dr. Srimati for the exclusive and very lucid presentation on antihypertensives, Dr. Gayatri who was in between her travel, who joined us for giving a talk about how her experience with Penai has been. Above all, Ms. Sahiti and the team from Shield Connect and Shield Health, who has been standing like a pillar with us for the connectivity and for going through the program so meticulously and without much of a hiccup. In all these things, people that you don't see are the people from the SFMI office who have been there. Anytime you message them regarding a PPT or anytime you ask them for a delegate detail or a faculty detail or anything that you come up as a hiccup, they're always there standing like a strong pillar, giving us all the help that we can get. And hence, they deserve a big round of applause and a big thank you from the bottom of my heart to have helped me so much. The senior members, Dr. Jyotika, Dr. Prakash Mehta, Dr. Kasturi, whom we would want to interact more often now onwards, Dr. Virendra Kumar, thank you all once again. Thank you for being a part of this.
And thank you, Shield, for the program.
Yes, sir. We would also want to thank Ms. Dr. Prachi, Mr. Zingade, as well as Sahiti Priya and her team, who've really made, given us this wonderful opportunity to take Penai across the country. Thank you so much. And it's gone even beyond the borders. So we are really happy. So we will be inviting the Bangladeshi delegates also to watch this show. So thank you so much, Shield Connect.
Thank you, ma'am, for giving this opportunity.
Thank you, everybody, and see you in the next program.
Yes, sir. Thank you, everybody.